Hi, welcome to The Vitals, here at Mount Sinai School of Medicine, where we have a great show for you today. My name is Raja Flores. I am the host today, filling in for Leslie Schlachter. I happen to be the chairman of thoracic surgery here at Mount Sinai, and today we are welcoming two experts in the field of exposomics. What is exposomics? Basically, it is a field that studies the effect of environment, different environmental factors that influence somebody's health. And we have two of the world experts here at Mount Sinai, Dr. Rosalind Wright and Dr. Bob Wright, and they head the Institute for Exposomics. All right, so welcome Bob and Rosalind Wright to our show today. And can you, and just for full disclosure, they're both married, just so everybody knows.
to each other.
To each other. And so can you give us a brief introduction as to what is exposomics?
I think the simplest explanation or definition is it's the study of all the health-relevant environmental exposures you experience across your lifespan. So it's meant to be a complement to the genome. So the genome is all your genomic risk factors for your health, and exposomics is all of the environmental risk factors for your health. Defined broadly, it's the social environment, it's the chemical environment, the physical, and even the biological environment. Things like infections would also be part of your exposome. And it's time varying. It starts when you're conceived and it goes on until the day you die.
So I'm a thoracic surgeon, and I operate on a lot of patients with lung cancer, mesothelioma, the cancer from asbestos, and esophageal cancer. Can you give an example for the audience as far as, let's say, lung cancer is concerned? How would exposomics come to play as we're studying lung cancer?
So everyone knows that smoking is a cause of lung cancer. Asbestos is also a cause of lung cancer. And there are genetic factors that make you have a higher risk for lung cancer. But what they're really doing is actually interacting with things that happen in your environment. So if you're exposed to air pollution and you have a genetic risk factor, it's the combination of the two that may actually trigger the onset of mutations and mutagenesis, and that ultimately lead to lung cancer. So exposomics is actually filling in a lot of the missingness of genomics. So we know that when people have a particular genetic variant, they're at higher risk for having, say, lung cancer or any particular disease, but not everybody with that genetic variant gets the disease. And the difference is what you're exposed to and when you're exposed to it. So it actually completes, the Human Genome Project.
I mean, I've always found that fascinating, where you can have two people smoking the same amount, same cigarette brand, one gets cancer and one doesn't. So I think that when you look at exposomics, that's the missing piece. That's the piece we can influence, because the genetics are there, and it's how do we influence the exposures. With mesothelioma, the cancer from asbestos, how would you study something like that? Because you have patients who are still being exposed, and some will get cancer, some will not. How can you study that and affect things in a way that will help the majority of the population?
Well, I think I'd like to say something about your previous question too, but it relates to this, is that it's not only the health-relevant exposures over your life course that might interact with your genome to put you at higher risk if you are exposed to certain things in the environment, smoking, chemicals, all the things that Bob was talking about. But now take the patient who has lung cancer, and you have to treat that patient. The exposome is not only the external environment that you take into the body, but it's how your body, your biology has been reprogrammed, because you have to adapt to that over time. This is the context in which you live, and your body is trying to balance how do I keep this person as optimally healthy as possible given all these exposures that they have. So physiology changes. Now you have to treat them with chemotherapy. And some people respond and some people don't. So it's not only that there's differential risk because you mentioned they both smoke, but only one ends up with cancer. That part of that's genetic, part of that's the environmental milieu from the outside that's taken in, and part of it is that reprogramming that happens. And we as physicians need to get better to think about that, measuring those things to get a little closer to how do I best manage this person. We may not get down to the person, but we're going to get down to smaller and smaller risk groups that we understand something a little bit more about and better manage. And I think with mesothelioma, it's going to be a similar story. It's really, we know that we're not exposed to one thing at a time. It's a mixture. And the exciting thing about Exposomics is we now have the computational science available to us to really more comprehensively study those things in the context of delivering healthcare and making diagnoses and preventing disease, which is the most exciting part to me.
It's interesting. You mentioned something that really resonated with me as a surgeon. So are we considered surgeons? Are we considered part of this exposomic mix? Because you have one surgeon that's going to treat a patient a certain way and another one. So it's a different treatment exposure where you have, me or one of my partners operating on you, and you may have a different outcome depending on who's treating that particular patient. Is that included in the exposomic captured data?
In theory, it is. It would be difficult to tease out the individual skill set of different surgeons. Patients have different degrees of severity, so that may play into that as well. But yes, you're right. It is at some level part of the exposome. And certainly procedures, medications that people are on, lots of things that you can get out of the electronic health record are actually part of the exposome. In addition to things like water quality and air pollution and exposure to chemicals and the built environment and diet. All those things are part of the exposome.
That's an interesting question because we often think in epidemiology, just looking at outcomes in the healthcare setting, we think about case mix. So that's kind of what you're getting at is case mix is really you're at this institution or that institution, this clinician is providing you a certain care approach. This clinician may choose another way to do that. It's that case mix. And you can account for that, but you can imagine that we need bigger and bigger data to do that. And the more we have that, and that's why I was mentioning the computational tools and data science and artificial intelligence or augmented intelligence, we have to have the clinicians right side by side with our data scientists helping to sort out and tease out what's important there. But that's where we're moving, and that's very exciting because that could get to the kind of question that you're asking.
It's interesting because the computational analysis we're getting better and better at that. We're better to record, absorb, and translate that. What is it that you try to capture? So you're looking at environmental stuff. Everybody wants something quantifiable to be able to explain something and to be able to change things to improve healthcare. What are you capturing? What are you looking at?
I think one of the biggest challenges is that we tend to approach science in a reductionist way. So if you think about how a randomized controlled trial works, half a group gets a drug and the other half gets a placebo, and we're trying to see the effect. There'll be a difference in many cases if a drug's successful, but we don't know why some people who got the drug, didn't have an effect. And that's sort of where exposomics can come in. Genomics is thought of this way too. Maybe there's a reason genetically why some people who get the drug don't have a good effect, and why some people who don't get the drug, actually there's a placebo effect too, where people actually get healthy. Exposomics is trying to understand the context at the individual level so that we understand that this person had a treatment failure because they were exposed to this, or this person was able to overcome the illness, which is a placebo effect, even though they didn't get the drug. And Exposomics actually gives us more information on the context of the individual, which actually is their diet, it's their environmental exposures, and it's even things that happen to them in childhood.
Can you give a simple scenario of how Exposomics has changed management in a particular scenario that has improved care outcome in patients?
Air pollution apps and asthma might be a good example. There's this new ability because of cell phones to understand at a personal level how much air pollution you're breathing. And so patients with asthma can actually gauge whether or not they should exercise outside or even go outside on a day that's really bad for air pollution. So there are ways that you can control your environment, which really didn't exist even 10 years ago. Like that information wasn't so readily available. So that's exposomic information. So that would be an example there.
Asthma is a good paradigm for that. So I'm a pulmonologist, so I take care of a lot of asthmatics, but an adult pulmonologist. But some of the research I do is really going way back, starting in utero and looking at factors collectively that program risk for asthma. And we've discovered a lot about what those health-relevant environmental factors are. And it goes beyond the things we thought it was, allergens and tobacco smoke and those kinds of things. And that's where I started when I was doing my pulmonary fellowship. But it was only explaining like 15% of what was going on, and that bothered me. Well, what are we missing? What are we missing? There was a study done in Baltimore where they had folks who, 12-year-olds that had asthma, very significant asthma. They were having multiple exacerbations, even on best drug that we knew should be good for asthmatics. And they were having more hospitalizations, more ER visits, and greater morbidity. And they moved them, they gave them vouchers, moved them out of these urban areas where there was disinvestment, high pollution, lack of resources, not good access to healthy foods, these kinds of things. They moved them out. Before they did that, they measured in their homes the air pollution level, the dust. They characterized their exposure to the allergens, tobacco smoke, all those things, as well as stress that they were experiencing. And then a year later, they looked at outcomes and they measured those things when they moved as well. And they said, well, we did see a change in those for the better, all those external environmental factors. We saw improvement in the asthma. Well, what was mediating it? And it was really the psychological stressors, more so even than the air pollution, the tobacco smoke, and the indoor allergens. But yet, they're also interacting to be synergistically impacted. So it's really, again, we started thinking we have to really measure these things collectively and think about them as a big mixture of health. What are they? And then the air pollution, ambient air pollution, outdoor air pollution from traffic, from industry, those kinds of things. That's now been linked to not only onset of asthma, but exacerbations or worse outcomes in asthma on high pollution days. The diet that you eat, we know that nutrition can actually mitigate the effects if we have diets that are high in certain things, advantageous polyunsaturated fatty acids, antioxidants, higher intakes of those. Even if you live in an environment where you're exposed to higher air pollution, et cetera, if you have a balanced, nutritious diet, and we knew what to optimize in that individual by taking an exposomic, scaling it up and taking a look at their nutrition, that would be very helpful. So there's data to show that. Even there was one study that came out where pregnant women smoking, we know it has huge impact on lung growth, and these kids are going to have problems after they're born. They're going to have smaller lungs. They're going to be at greater risk for chronic lung disease like asthma and others. And it's very difficult sometimes to convince people to stop smoking or it's an addiction. So even pregnant women, lots of folks can be motivated by I'm pregnant, I'm the baby, but some can't. And they randomized mothers who were smoking during pregnancy to vitamin C, and they found that if they could give vitamin C, an antioxidant in utero, they didn't see those lung impacts on the kids. So there are those kinds of studies. And one more I would mention recently I was involved with is not only looking at the physical chemical exposures we've talked about, but the social environment. So stress, if you live in an environment with high levels of psychological stress, unsafe environments, these kinds of things, just as you breathe in tobacco smoke, it triggers changes in your physiology, the HPA axis, cortisol that you put out, the autonomic nervous system, those connect to the immune system. Asthma is an immune-mediated disease, so there you go. You can make that direct connection. So people are starting to do that kind of work. We need to scale it up. That's starting.
So interesting, with cases like that, let's say homelessness, more stress, high cortisol levels, decreased immune system functioning. Do you draw blood in those patients to document the elevated cortisol? Do you just take prior studies that say, this leads to higher cortisol levels and in turn, or do you actually draw blood and check on that?
We measure it. Drawing blood, first of all, you put a needle in somebody's arm, their cortisol is going to go up. So it's not the best way to do it, but there are non-invasive ways you can do it. And cortisol is different over the course of a day. There's a diurnal rhythm to that, so there are lots of those. So we take saliva samples, repeated saliva samples from people. You can measure it in that. And there's some very interesting work that's come from hair. You can, if you take hair just at the root and you start to go back, each centimeter represents a month. And you can actually measure hormones in that. You can measure environmental exposures in that. You can measure lots of different responses, physiologic response variables that can say you get somebody a delivery of a baby and they give you 9 centimeters of hair. We can recreate the whole pregnancy from that hair sample that
is amazing.
So those are the kinds of innovations that we need to really be taken advantage of for exposomics, something where you can measure multiple things, not only the exposures, but the biological responses that we think are operating underneath. So we have insights into those as well at the same time.
So it's interesting. Let's say for a disease like mesothelioma that you get from asbestos, we see patients in the office where they don't know if they were exposed, right? And the scan doesn't show any evidence of asbestos in the chest. And they think they may have been exposed, but you're not sure. Is there a way to check hair or something like that where you can see if they've been exposed to asbestos in the past?
I don't know that there's a biomarker per se, but we know where asbestos mines are. We know the occupations that tended to have higher levels of exposure. Like Steve McQueen was exposed, I think, during the Navy, his stint in the Navy and the work he was doing there. Construction certainly gets that. So there are pieces of the puzzle that we can actually use to estimate the probability that you're exposed. Like, where did you grow up? We as physicians, we never get a lifetime residential history. Yet there's amazing information in where you used to live. Whether you used to live in an urban area that might have been a food desert, or you lived in a suburban area, or maybe you lived in Libby, Montana when you were a child and you were probably breathing in some of the particles of asbestos. So there are ways to reconstruct that. And that's really part of what Exposomics is actually trying to map your history. And so we will get some biomarkers. We some of them might be in hair, might be in blood, or might be in urine, and we can measure lots of chemicals as well as hormones and get a sense of what your body's doing today. But with maps, we can also go back in time and give you some information on what you may have been exposed to earlier in life. And I think that's the real power of Exposomics. And I think the growing interest in Exposomics is really tied to the fields of longevity, which has gotten a lot of press recently, but also health span. So not just how long you live, but how healthy you are how healthy you are as you live. Exposomics ties to that, because if you're having inflammation, there's something happening in your environment. It might be your diet, it might be chemical exposures, it might be air pollution, it might be a past history of asbestos exposure that may have triggered, a tumor that's somewhere in your body. There's some signal there. And rather than just stop at saying, yes, there's inflammation in your body, Exposomics goes deeper and tries to figure out what the root cause is.
I think that's very relevant, because many times when I have a patient who has a cancer, whether it's mesothelioma, lung cancer, esophageal cancer. They want to know if they were exposed to something in their home because they have other family members who have the same genetics who are also exposed to that environmental insult that can trigger a cancer. So if we can use Exposomics to figure out what was it that they were exposed to and where, you can prevent cancer from happening in their family members. Because that's really the number one thing patients will ask me after I'm treating them. They worry about their family. What do I do with this?
Right. That's a very good example of how it could be used in a very important way.
I think that is pivotal for the patients that I see. Many of them are blue-collar guys, insulators, who were exposed at work. And it's interesting is over time, you found out that their spouses got cancer as well. And it's because they came home with the stuff on their clothes.
Right.
Yes.
And the spouse would clean it and they developed the disease as well.
Right.
Yeah, so one of the values of Exposomics is we go beyond blood tests. We might actually, if we wanted to do a full exposomic analysis, say on you, we would go into your home and collect dust and then measure what's in the dust. Because that's what you're breathing on a day-to-day basis. And, think about how many hours you spend in your home, breathing the air in your home. It adds up over the years. And so, it's very important to have healthy air. It's very important to have healthy water or clean water. And so, these are things that we can actually modify, but we have to measure them to know whether or not we need to modify them. And Exposomics is giving patients agency so that they can see what's happening in their environment and they have the will to change it if they so choose.
Yeah, and there's going to be an explosion of wearable devices because that's going to really allow people to do that sort of monitoring where they are, where they live, where they work, in schools where kids spend a huge part of their day. That's going to be important data to have, both for the clinician but also the patient, because the patient can monitor that with these wearable devices.
It.
And you, as the clinician, can be guiding them on, well, here's what you do in that situation as well. We need to learn to work together with those types of devices. We need that kind of information more than seeing the patient every 6 months or once a year or something like this and trying to recreate it through a history. We can actually measure the effects. These things are not only the exposures, but the effects they're having on your body. We can monitor, and your nutrition. You can monitor what you're taking in, understand how that affects you, that kind of thing. And then it's like tuning a radio. Where do I? Well, okay, this person they're up on this, up on this, up on this. Well, let's talk about how you can minimize those exposures. That's always important. But in the meantime, there are things we can do. We can fix your nutrition a little bit in this way. How do we make that happen for you? Now, some people don't have access to healthy foods. We have to take more of a public health lens there than just telling people advice, you go out and buy, this or that.
It's interesting, before we get into nutrition, because that's probably one of the number one questions many patients ask.
Yeah.
What, if they have cancer or if they don't have cancer, what can they eat to avoid it? The home issue, though, there's one question that I have. How about, let's say, for example, a fireplace? Can you tell if you have an active fireplace in someone's home? Is there something coming out of that can be an exposure that can trigger some kind of cancer or something in an individual? Has that been looked at all?
I think smoke is clearly a carcinogen. I think there are air filtration devices with HEPA filters that you can use. And you can make sure that you keep your chimney cleaned on a regular basis so it doesn't back up, which is also a safety issue. Yeah. So there are things you can do. You don't necessarily have to stop using the fireplace, but if you want to understand your health and you want to promote your longevity and your health span, it would be wise to counsel patients to look into these things if they can afford it. Get your chimney cleaned, you can get your air checked, and you can also get a filtration system. So those are things that are all possible. And they can have big effects because, you can't stop breathing.
Yeah.
I think we underestimate how powerful clean air is until we start to think of how much air we breathe just in a day. We take about 150,000 breaths a year. Multiply that by the number of years you're alive. So that just tells you how much air you're taking into your body. And if it's polluted air, that effect is accumulating over time.
Yeah, and if that's in your home, it affects things like sleep, more short-term things too. Sleep quality is hugely important to almost any health outcome that you want to look at, but even longevity. You have to have good quality sleep. So it affects those things in the short term. For cancer, those are harder studies, right? Because there's such a long latency period so you really would need some measures of cumulative exposures over time. That's where some of the innovations that Bob was talking about mapping, going back in time, that we can go back in time and recreate, similar to how we were talking about using hair to recreate a longer period of time when you're looking at these different biological factors as well. We need to be creative and invest in doing more of that kind of thinking to be able to do that. At the same time that we know going forward, we really want to know these things about people. Like you were talking about earlier, we're better at what we put in the health record because we know those data can be very valuable. And we weren't doing that as thoughtfully in the past. We can still do better, but we have made strides there.
Yeah, I think as physicians, we tend to think of doing blood tests, and that's what's valid. But there's a lot of information in, say, getting your house dust, getting getting your air filtration system, getting a filter and measuring what's in the filter. There's a lot of information in maps, knowing where you grew up and what was in the areas where you grew up. Maybe you grew up next to a Superfund waste site and you never knew because you were a kid. Yeah. But that information is retrievable, and maybe you were exposed to carcinogens because of that. I was born in Okinawa. My father was stationed there. My mother was Okinawan. I grew up across the street from Kadena Air Force Base. Kadena Air Force Base during the Vietnam War had a lot of Agent Orange contamination. So I may have been exposed to Agent Orange when I was a child. But that's information that I only learned because I decided to map my residential history, and I looked into it more. So there's a lot of information on your potential health that actually won't necessarily come from a blood test.
Yeah, it sounds like there's a wealth of information that you can find out about your past, I think, and what you've been exposed to and how that's going to affect your future. So starting now, nutritionally, how do you figure out, especially nowadays where there's ultra-processed food, everything is contaminated with this or that, how do you study food and how it affects whether or not you get cancer, your longevity, your quality of life? How do you begin to study something like that?
Well, we know obesity is a risk factor for cancers. So food that is obesogenic, so high carbohydrate diets, regardless of whether they're contaminated with chemicals or from ultra-processed foods, just that diet alone is going to be pro-carcinogenic because it's pro-obesogenic. And so, I would recommend a high-protein, low-carbohydrate diet with as much green leafy vegetables as possible. That's hard to do. I think we have to factor in that people have a hard time getting off of ultra-processed foods. Part of it is the cost, but part of it is they are addictive. And so we have to understand that this is an addiction. I think GLP-1 drugs will really, really help people. I think most people don't want to be on a drug for the rest of their life. So I think they're useful for breaking the cycle, but at the same time, as clinicians, we have to give people the tools so that they can learn how to eat healthy. And it doesn't necessarily have to be expensive. I think it's a bit of a cop-out for the food industry to talk about how inexpensive their foods are when they're basically unhealthy foods. So we need to think about how we can provide healthy foods at a reasonable cost to people, but also give people the information about, if you eat this product, it's much healthier. If you hit a high protein diet, low carbohydrate diet, you're probably going to either lose weight or at least not gain weight. And that's going to be better for you in the long run.
And how do you study it? I mean, we have to measure it as comprehensively as we can, nutrition. beyond sort of these larger categories, right? Processed foods, et cetera. But that's where you get into the internal environment, and where you can actually use omics platforms and really on a scale of thousands take a look at those data using machine learning, AI, those kinds of tools to start to see patterns that are predictive of certain disease outcomes. And we need to do more of that work. That work's going on, but we need to do even more of that work. And then in the individual right now, characterize that, make a change, and then follow and see if you do see improvement in those patterns and profiles. It really is going to be more than just a blood test, one biomarker. It really does need to be a more comprehensive
So what's your
evaluation
most
of that.
useful tool? Is it the electronic medical record where you can extract all this information? Or what is your most valuable tool to plug something in and look at the omics?
I think it's all of the above. I think it's the electronic health record. I think it's the maps. I think there is definitely a role for measuring your blood exposome. So if we're measuring, the chemicals in your blood, which will include things like hormones and nutrients and metabolites. So all those things come together. I don't think there is a game-changing one thing. It has to be trying to bring these things together. And as Raz said, trying to figure out your past, because you're not sick today unless you were hit by a car or you happen to catch an infection because of what happened to you today. You're sick because of things that happened to you in the past. So if we want to understand cancer, we have to be able to go back in time. And so a lot of our work is actually thinking about how can we go back in time and trying to think outside the box, because physicians don't typically think about maps. But maps they're very easy to understand because they're so visual, and they go back in time. Everybody's looked at a map from the 1960s or 1950s when they were born in their neighborhood and seen how it's changed. People use maps all the time, and so maps are just intuitively easy to understand. So if you grew up in Libby, Montana, and you could plot where your house is, and you could plot where the mines are, and you could probably even get information on the wind direction, or the average wind direction over time. You could actually estimate your exposure. So
interesting. So just regular maps are
a
wealth of information.
Getting an address, making sure that you can link that address, not a zip code, where you live, right down to what area that person's breathing, and estimate those kinds of things. It's really what Bob's saying. It's making those multiple data streams interoperable and investing. Like our health system has really done that in a big way, invested in high performance computing, linking genomics with the electronic health record, but also now we have to bring in the environmental pieces, these maps, but also the biomarkers that we're measuring as part of that, the exposures that we get from the wearable devices that we have, the responses that we're measuring in people out there living in the world through the wearable devices, et cetera. All those data need to be interoperable and really streamed together. And that's the kind of thing that they're building. Many health systems are trying. I think we're way out ahead of that thinking and investment in that. And that's what's going to happen is really bring those things together. Using Medicare data, right? Leveraging a lot of these existing administrative databases. That brings us interesting data. You can link that then to air pollution exposures or other exposures that you can model based on where someone lives, and you can actually start to really hone in on hot spots of why are so many people here getting mesothelioma. A little more readily than we had in the past, and really use those tools.
And, there's a great quote from a science fiction writer, William Gibson. The future is already here. It's just not very evenly distributed. And what he means by that is all these tools exist, but they're very siloed. And so with artificial intelligence and the computational infrastructure that we now have at Mount Sinai, we can start to bring it together and make it more evenly distributed so that we can start to use this information. The problem isn't the lack of information, it's how siloed it is. And so what we're trying to do with Exposomics is bring all these different pieces together, including genomics. But we want the exposure biomarkers. We want the measures, the biomarkers of inflammation. But we also want the maps. We want to know what your residential history was. Where did you grow up? Where were you at a particular given place and time? And what was happening at that place and time? And that information exists. So it just has to be brought together.
Interesting. You said something that made a lot of sense. If you're sick today, it's because of something that happened in the past that got you sick. So me eating Lucky Charms every day since I was 10 years old, what am I going to have down the line? But you can't really...
Looking at you, I don't think that happened.
That doesn't mean you can't do something now. You have to take that life course perspective to really understand why you're where you are right now. But that doesn't mean you can't, there's not things we can do to reset.
It's never too late.
Put you back on a more optimal trajectory, So it's not like it's all, you shouldn't throw up your hands and say, okay, well.
No, the importance of lifestyle, you can't underestimate it, because you will, even if you have mesothelioma, if you eat a healthy diet, and obviously you want to give up smoking if you're a smoker, but if you have social connections, if you eat that healthy diet, if you avoid toxins, you will feel better. It won't necessarily cure your disease, but it will probably increase your lifespan.
Yeah, it might make you respond better to medications that we have
I believe that. I've seen that.
Absolutely, I have as well.
Yeah. And exercise as well.
And exercise will do that as well. Yeah, there are many lifestyle factors that you can.
What is interesting to me is that you make it sound like the answer is out there and the data is out there. We just haven't been able to put everything together. It's like the puzzle is all over the place. We just got to put the pieces together. But half the fight is not knowing what exactly you're looking for. So how would you put together or improve what we're doing here? Because we're already ahead of the curve at Mount Sinai with your group. How do we make it better? How do we make it so that we can affect the health of more people? And how can our viewers participate in that so that they're part of the solution?
Well, I think a lot of what Roz is doing with the CTSA is to build maps. So we've hired health geographers. So these are data scientists that just make maps. And another beautiful thing about maps is you can map anything. You can map your genome. In fact, geneticists do this. That's how, not 23andMe, but the other company, Ancestry.com. That's how they make their living, is telling you like where geographically, your ancestors came from. So everything can be mapped. So inflammation can be mapped. Mesothelioma cases can be mapped. Like where people lived as a child who have mesothelioma today, even that can be mapped. So, maps are sort of the great equalizer. You can put everything on a map. And I really think that is the future of medicine, is we're going to start looking at maps to understand what happened to people 10, 15, 20, 30 years ago to help us actually diagnose patients and possibly even help treat patients, because it might be information there that might actually lead us down a different pathway towards treatment.
Mm-hmm. Yeah, that's an important piece of it. We don't know everything that we have to have. All the data that we need is not necessarily out there, but what we should understand is a lot of it is. And we don't have to know everything to make huge strides forward. We know a lot about the health relevant drivers of multiple chronic diseases that we understand. Mental health as well. We talk a lot about physical health, but the same for the mental health outcomes. But we need to build that infrastructure that allows all those data streams to come together so that we can actually have our data scientists help us think through how do we best analyze this data to find answers for different, it's got to be disease agnostic. It would be useful to all in the end. And at the same time, we need to invest in more wearable devices, developing those, because we know we need that information. We know we need to have folks monitoring in the ambulatory environment in which they live, even more than we can do now. And those wearables are really going to help us do that. And then you have the infrastructure there, and now you feed that data in, and you start to put that into your computational models. So we need to do both. We're already have an infrastructure that allows a lot of this data to be interoperable and used in that way. There are things we need to do better to bring in the geospatial mapping data that we can, but in the wearable devices, and to sort of boil that down into an understandable parameter that clinicians can utilize in the clinic as well and advise patients on.
So a map, how do you construct a map? And do you use ChatGPT for that? How do you construct a map?
We do use AI, not specifically chat.
Like what other AI?
First we have to get a data set. So the simplest example would be air pollution. So
and it's in an Excel sheet, or what would this data set come?
Well, I'm not the person making the map. So
it's huge amounts of data.
There are billions of data points.
It's like hourly measures of the air pollutants, but you're also looking at traffic patterns. You're also measuring weather and temperature. And
is this government data?
Yeah, it comes from NASA.
Some of it comes from NASA. Some of it comes from the Environmental Protection Agency.
So,
the EPA has stationary monitors all over the country, more in some places than others, that measure certain pollutants that we know are health relevant. And those they take data from those, so they'll get that from the EPA, the modelers will, and feed that into the models that they're building as well. They look at land use regression, what's it being used for? Is there industry nearby, et cetera? An airport, other sources of pollution, that wildfires are another one that has to be thought about.
The simplest way it works is to think of it as, you have the satellites up in the sky, and they're measuring how much haziness there is between the satellite and the Earth. And then you have these monitors on the ground that EPA established, which have the actual truth, the measurement. Because you don't know whether the haziness is a mile high, in which case you're not breathing it, or it's right next to the ground. But the monitors tell you whether it's right next to the ground. So you calibrate the haziness based on the monitor. And the monitors are spaced in a certain way, and you use AI to understand the gaps between the monitors. And you can use, as Raz said, point sources to also supplement that, because that's going to add to the haze. And you can also factor in wind and other variables. And also cloudiness. Cloudiness makes it harder to see that haze, obviously. But you can use AI to fill in the gaps of where the clouds are. And so our ability to make really accurate maps is actually much greater now because of AI.
Yeah.
Just like it knows how to anticipate a word there, it can anticipate a cloud.
Exactly, and what the cloud is blocking. Yeah,
that's right. Yeah.
Interesting.
And we map other things other than air pollution, and weather. We also map, businesses. So you can get into an administrative database, and you can know whether or not this area is a food desert. There's no supermarkets in this area. So, we can understand what's called the built environment. We can understand whether there's parks and areas to walk in your neighborhood. So we can make what we call walkability scales, which tell us whether or not you live in an area that promotes exercise or tends to inhibit exercise. So there's all kinds of information that you can get from maps. And also you can see how that changes over time. So, it also goes back in time, all of these maps. And again, if we have information at the individual level on inflammation, and we know where somebody lives, we can actually map the inflammation, and we can see whether there's a spatial pattern to the inflammation. So maybe there's something going on geospatially in this one neighborhood. We don't know what it is yet, but we know there's something about this neighborhood that we should be looking into. And so that's another value of the map, is it can actually provide information that's sort of sentinel, so that we can see that there's something going on here that actually should be looked into from a public health perspective.
No, I think it's fascinating. And I think, nowadays with all this big data around and different ways to evaluate it, who knows what else there's going to be in the future that can give you guys more tools to help human beings. I think it's amazing. It's kind of like detective work. You're looking at something and you're trying to figure out a pattern and a puzzle and solve the crime.
Right.
Which is the disease.
Yeah. Exactly.
Yeah. And actually, as we do it, as we start to show the power of that to improve health outcomes, to prevent disease, to improve response to therapies in certain patients, that's going to then show the value of it, the cost effectiveness of it. It's going to increase longevity, and there'll be more investment in the tools, like as you say. So it's a very exciting time. I think we're just at a point now where it's really going to take off because of those things. We've already shown benefit of it, but
and people
it's just
want
going to
this
be
information.
exponential.
Yeah, I mean, people want it because of they're interested in their health, the health span movement and the longevity movement. They want the information that they can, as we were saying, take agency on and decide for themselves what they're going to do about it. But they have to have information to do that. And, this is a technological age. This is the age of information. So people are demanding this. And I think there's going to be a lot of commercial aspects to exposomics that come up in the next few years.
Yeah, no, people are educating themselves with social media, the internet. They're out there. They're looking at it. When they come to see me, they've already done their homework. Do you have some examples of how there has been intervention in the public health sector that has improved things? Plain examples that the audience would have heard of or understand as far as making public health better based on this data?
Well, the Clean Air Act did have a major effect on lowering the amount of air pollution. Like when we were children before the Clean Air Act, there was a lot more air pollution that we faced when we were growing up. And taking lead out of gasoline, which happened in 1989, also reduced the blood lead levels in the country of everybody. The average blood lead level was greater than 5 micrograms per deciliter, which for folks that don't understand, place that in context, it's less than 1 microgram per deciliter now because we took lead out of gasoline. So those are both examples of how there were public health interventions that actually very likely improved the health of the population. Like one of my concerns is because our generation grew up in the era of leaded gasoline, we were all exposed to lead, which is a neurotoxin. And does that make us at higher risk for Alzheimer's disease? We're not quite at that age yet, but it is something to think about whether or not that childhood exposure that happened in the 1970s when use of leaded gasoline was peaking actually may, and when we were children, may actually lead to Alzheimer's disease.
I have thought about that.
50 years later.
I think that's a great question.
And it's sort of like mesothelioma because there's a long lag between the two.
Yeah.
So it hasn't been noticed yet because we haven't reached the age where we're getting Alzheimer's disease yet. But in the next 10 years, we're going to reach that age.
Yeah. I forgot the next question I was going to ask you. See, it must be doing something.
There's a, there are other examples to what Bob was talking about. So banning smoking in public restaurants, et cetera, secondhand smoke, reducing secondhand smoke exposure. There's been a lot of data to show that improves a number of health outcomes, whether it be respiratory or others. Yeah. And then you think of natural experiments like the Beijing Olympics. When they stopped all it's one of the most highly polluted areas in the world. And when they changed traffic patterns around the Olympic Village, et cetera, during that time, people took advantage of that. Scientists took advantage of that to measure the pollution pre and post and also go in and actually take samples from people and look at their biological response and showed clearly the benefits to the immune system, to reduce inflammation in the body, and all those kinds of things. So,
and their health records show that asthma admissions decreased during that time.
Yeah, I mean, I got to tell you, I feel better after Bloomberg stopped the smoking in public places stuff. You'd go into a restaurant or a club or something, and you'd inhale all this secondhand smoke when we were younger, and now you can actually breathe in there. One question that I had, trying to look at this in real time, during COVID, did you see anything from your area that you think helped or could have helped with regards to as COVID was hitting? Was there anything you would have done differently looking at people who were at more risk of death? What is there anything that you have learned from the COVID experience?
Well, I think, the mapping, it keeps coming up because mapping sort of communities that had higher risk
Public
was
housing,
very important.
mapping.
Right. And a lot of that was the environment.
Yeah.
The environmental factors that are affecting things like the immune system and your ability to fight off infections as they come along was different if you were living in an environment where you're exposed to lots of things that were sort of triggering and pushing that immune system in a certain direction. People who are living in environments where there's more oxidative stress induced by your environment, and that's tobacco smoke, that's a lot of the air pollution components that we think about, but psychological stress can do that too. So higher levels of stress can certainly suppress your immune system and ability to fight off infections, and that's just as true of COVID as it is of any other. So understanding those, and again, this person comes to you now. They're intubated in your ICU with COVID. First of all, there was so much we didn't know about the disease, but you don't also know where this person has come from.
Yeah.
To the point where, having that information and taking that kind of history can be very helpful. And we need to learn as clinicians, we need to learn to translate that to the clinical setting better so that we understand how much do we need to know, what's enough so that we can make different decisions there.
I think the number one public health issue in America today is obesity. And if we could make a dent in obesity, first of all, it was a risk factor for higher morbidity and mortality during COVID. It's a risk factor for Alzheimer's disease, cardiovascular disease, cancer, diabetes, and all the complications of diabetes. I think if we could reduce obesity, we would actually save a lot of healthcare dollars.
Oh, I completely agree with that. I mean, I operate on esophageal cancer, and you think because you have esophageal cancer, you can't get food down so you'd be skinny. No, it's obese patients who get more reflux because they're obese, and then that reflux in the esophagus then predisposes you to getting cancer. So many of the patients I operate on with esophageal cancer are actually obese. So it's a little counterintuitive.
And we're all old enough to remember, the 1970s, and obesity was uncommon back then. And, our genes didn't change in the last 50 years. Our environment did. So whatever is causing this is environmental. And that's where we need to look. Because, if we're going to make a dent in this, we really need exposomics.
So now I'd like to do our lightning round where I throw out something and you guys tell me whether it's harmful or not. Now, of course, we understand there's a lot of nuance in things and length of exposure. Just, your first instinct, harmful or not harmful. Air fresheners.
Potentially harmful, the particles that come along with it and the carriers. But you have to know what's in them.
Yeah.
Yeah.
Non-stick frying pans.
Those have forever chemicals in them. I would try to buy the ceramic versions, which have less of that or none of that.
Candles.
There will be smoke, and where there's smoke, there's carcinogens.
Well, again, candles, and then they have scents in them, and it's what's in the candle.
Yeah.
But you're right. You're burning it. You're letting it out into the air. These are things you're going to be taking in through your airway. And if you have small particles in there, they get through, and they induce some of the changes that we're talking about with the immune system, and et cetera.
And I would like to add the caveat that anything in moderation probably isn't going to hurt you that much.
It's
but
length of time too, duration.
Constantly is the problem.
Mothballs.
Older mothballs have naphthalene, which can be quite toxic. Occasionally, young children will accidentally ingest it and get very, very sick. The newer ones have perichlorobenzene, which is less toxic, but it is off-gassed, and so I don't recommend it. Things like lavender tend to work better for mothballs, and they're natural.
Microwaves.
I think the science is still out on microwaves, so it's not clear to me whether they're toxic or not.
Dry cleaners.
There's a lot of chemicals in dry cleaners that are potentially toxic.
If we were making a map and you lived above a dry cleaners, I would consider that something that would be potentially interesting about your history.
Drain cleaners.
they don't use really strong lyes like they did when we were children. They're more sodium hypochlorite, which is a mild bleach. So you should read the label and make sure you know what's in it, because you can buy the really super strong ones if you need it, particularly if your father or someone in your family is a plumber. They may have access to it. But read the label as to what it is. If it's sodium hypochlorite, it's most likely not that toxic.
And the last one, cosmetics.
It's a lot of different. That's a big category.
You know, it's
and
interesting.
those are things you use every day, and so it can
Yeah.
become an issue. And a lot of the chemicals that Bob was talking about are in a number of cosmetics. Again, you have to know what's in them. A lot of people are moving away from, going more natural, particularly young people.
Yeah.
When you think of young people who want to start wearing makeup, and they're still developing rapidly through that preteen and teenage years. I am so concerned about that.
Yeah.
Knowing those chemicals are there and understanding how they can get in and affect all things, all kinds of things in the body, and just, change your hormone systems, et cetera, which are so important to that.
There's
period.
a recurrent thing that you both keep saying, and it's you got to read the labels.
Yes.
You got to know what's in it. And it's interesting because cosmetics, at one point, we were importing cosmetics that had asbestos in it.
Yeah.
So I think your point is very well taken. There's many times that we use these substances without knowing what we're using. You got to read the labels, read the ingredients, and know what it is that you're putting in your environment.
Yeah. And you go to different parts of the world where they're not regulating some of those things. And I've seen eyeliner with lead in it, and there's all kinds of things that can be in those products.
Yeah, I mean,
hair products are another one that
I'm
you
sure,
can be
like hair
exposed to.
dye.
Mm-hmm.
It's
Straighteners.
interesting because from the business guys, get rid of regulation. Regulations are horrible, but regulations actually save lives, and that's why they're in place. So resources for listeners. If a person has a concern about environmental exposure, how do you get information and access to care? For children, we have an environmental pediatric team. Parents requesting consultations through Region 2 Pediatric Environmental Health Specialty Unit in New Jersey, New York. Telephone number is 866-265-6201. Email pehsu@msssm.edu, and we have our website flashed on the screen as well. And how can listeners, whether you're scientists, students, healthcare workers, or just concerned citizens, learn more or advocate for this kind of research and protection? We have the Mount Sinai Exposomics link on our screen, MountSinaiExposomics.org. And if you're part of a community group or an organization, we'd love to connect with you. And you can invite some of our researchers to speak at your community. You can email us at podcasts@mountsinai.org. And I just want to thank both of you for coming today. I learned a wealth of information, and I think that this is the future. We have the data in front of us, and it's better to prevent disease than to cure disease that's already there. And this will help cure or prevent disease in many patients. So, Roz, Bob, thank you guys so much for coming. I appreciate it.
Thank you. And well said.